In the previous section, we have seen in detail regarding the overview of ILDs. At the same time, we have seen a lot of CT appearances, classification, and what are the DDs for those CT appearances and all. But in this particular section, we are moving on to the core details of the ILD. In that, the first thing, ILD due to known causes. In that, the first component will be the smoking related ILDs. There are three disorders in this group. Under this group, one is the respiratory bronchiolitis interstitial lung disease, RBALD. Then you have desquamative interstitial pneumonia, DIP. Then finally, you have your pulmonary Langerhans histiocytosis. Before going into the core details of each and every of these things, we'll see what are the common things between them. So number one, obviously, is smoking. All of the patients will be smokers, whoever get these disorders. Smoking has a very, very strong etiological relationship with these disorders. And second thing is the fact that they'll be extremely common in males, and that too around 30 to 40 years of age. Absolutely clear. Which means they'll be relatively young age. And very importantly, the most important treatment for these disorders will be smoking cessation. Stop smoking, quit smoking. That's the most important component of the treatment. At the same time, they'll have a very good response to steroids, corticosteroids. Very, very good response to steroids. Clear? So these are some of the common features that are going to see in this disorders. And one more thing is the fact that clinical feature wise, most of them will be presenting with dry cough, with or without dyspnea, shortness of breath. So many times the progression tends to be relatively chronic. They won't present very acutely. They'll be relatively chronic. And when you do a CT only, you'll be finding out that something is wrong. This is not just a smoker's cough due to bronchitis. This is something else that is happening in the lungs of these patients. And one more important thing, I told you most of them will be presenting with dry cough and with or without shortness of breath. Yes, that is true, and I'm not denying that fact. But this Langerhans histiocytosis only has a very high chance of getting a pneumothorax. So because it's a cystic disease, which you'll see in some time. But before that, let me write the disorders. The first one which I'm going to discuss is on the respiratory bronchiolitis interstitial lung disease. Second one I'm going to discuss is on the desquamative interstitial pneumonia, DIP. And the third one which we're going to discuss is on the pulmonary Langerhans histiocytosis, LCH. The only difference is the fact that the PFT will be definitely different. The pulmonary function test in a patient who's having RBALD, they'll have a combined restriction plus obstruction, mixed RLD plus OLD. Whereas desquamative interstitial pneumonia is a pure restrictive lung disease type, whereas your pulmonary Langerhans histiocytosis will be having restrictive lung disease, but the morphology, the PFT features will be like restrictive lung disease, but they will have a preserved total lung capacity. This is a very, very important point. So they'll have a preserved TLC despite showing a RLD-like picture. Fine. So this is all about the pulmonary Langerhans histiocytosis. At the same time, I told you the pneumothorax is one of the important features of pulmonary Langerhans histiocytosis. Whenever you think about an ILD causing a pneumothorax, think about only two disorders in exam. One I told you is lymphangioliomyomatosis, which we'll discuss later on. And then you have to think about pulmonary Langerhans histiocytosis, because these are the two ILDs that tend to be cystic with air pockets, and when they rupture, they can result in a pneumothorax. Okay, so now after knowing all these things, let us see the CT appearance. So what is going to be the HRCT appearance? HRCT appearance will be typically, if you take an RBALD, it's going to be upper lobe predominance will be there. So which means they are going to be predominant in the upper lobe. At the same time, they are going to have this kind of centrilobular nodules. Centrilobular nodules. Typically, mostly in the upper lobe. At the same time, there will be a ground glassing. A minimal ground glassing, not like, like extensive ground glassing like what you see in the NSIB, which we'll discuss later on. I told in the overview of ILDs. But here you will see a little bit of ground glassing. But anyways, that will be predominant in the upper lobe. In the areas of ground glassing, you will be seeing the centrilobular nodules, which are very, very characteristic. So that's what you are seeing here. You can see there is a bit of ground glassing here, not like extensive bit of ground glassing. All right. At the same time, you can see the centrilobular nodules. Can you see this? These are the centrilobular nodules. Clear? So these are some of the examples of this centrilobular nodules. Fine. So this is a typical feature, HRCT feature of a respiratory bronchiolitis ILD. So what will be the CT features, HRCT features of a desquamative industrial pneumonia? They don't typically involve the upper lobe. In general, overall, they have something called a peripheral predominance. You can see it is only affecting the peripheries of the lungs, which means typically they have a peripheral predominance. And in these areas, you will see a little bit of ground glassing, not extensive like NSIP, but still a little bit of ground glassing you can see in those areas. At the same time, you can also see irregular and linear opacities. These are irregular and linear opacities. Irregular and linear opacities. With some nodules also you can see in between. The nodular distribution may be centrilobular or random, but the most important is the irregular and linear reticular opacities. Let us see what's going to happen. So here you can see very clearly you are having a peripheral predominance with a ground glassing appearance in these areas. But here you can see very typically this area is the one that is ground glassed. Very, very classic. At the same time, you can see in the peripheral areas, you can see a lot of linear densities like this. These are due to interstitial thickening. These are linear and irregular reticular opacities. You can see these are very, very classic. Clear? So this is typical HRCT finding of a desquamative industrial pneumonia. Then when you go to pulmonary Langerhans histiocytosis, this we have discussed already in the overview of the ILDs itself. It's a very important cystic disease. It's one of the examples of a cystic lung disease, and that is the reason it's resulting to pneumothorax. Very peculiar finding. And you can see the pneumothorax here. This image I've showed you already in the previous video. This is an example of a pneumothorax in a patient with the pulmonary Langerhans histiocytosis, and you can see the cysts here. You can see the cyst here. And very important fact is the one that this is an upper lobe predominant disease. Plus or minus it can affect the mid zone, but very importantly you have to remember this is a upper lobe predominant disease. And it's going to definitely spare your basal areas and CP angles, costophrenic angles. These areas will never be involved in pulmonary Langerhans histiocytosis. So you're going to have upper lobe predominance with a lot of cysts seen in the upper lobe, plus or minus a mid zone also may be involved, but it will definitely spare the costophrenic angles and the basal areas. It's impossible. Okay, now let us go for the biopsy findings. Biopsy is definitely needed for definitive confirmation because the CT appearances can be seen in some other disorders also. It might confuse you sometimes. So biopsy is one of the definitive diagnostic techniques. So we do a biopsy and see what is going to happen. In both respiratory bronchiolitis as well as your desquamative industrial pneumonia, you will see characteristic kind of pigmented macrophages which contain this cigarette smoke pigments. So these are called pigmented macrophages and they are called as smokers macrophages. These are called as smokers cells or smokers macrophages. And accumulation of these macrophages is very characteristic of both desquamative industrial pneumonia as well as your respiratory bronchiolitis ILD. But where this smokers macrophages will accumulate is the question. If you take a respiratory bronchiolitis ILD, typically you told it's a respiratory bronchiolitis ILD, which means the inflammation and the macrophage accumulation is going to be typically centered around the respiratory bronchiole, which means it's bronchiole centered. Bronchiole centered inflammation and bronchiole centered accumulation of this smokers macrophages. And it might be present in the alveoli also. In this example, you can see these are the examples of some pigmented macrophages. You can see some examples of pigmented macrophages which are accumulating in the alveoli. At the same time, this is a bronchiole, and within the bronchiole, you are seeing this inflammation. So the inflammation is typically bronchiole centered, and at the same time, you will see this smokers macrophages. That's why it's called a respiratory bronchiolitis interstitial lung disease. So then this is a desquamative industrial pneumonia where the only difference is the fact that the inflammation is not bronchiole centered here. Inflammation is not bronchiole centered, which means in the bronchioles you won't see that much typical inflammation. Here also you will see the Smoker's macrophages. You can see these are the brown macrophages or Smoker's macrophages or Smoker's cells. These are pigmented macrophages that you can see here also. You can see if you zoom it and see, you can see these are all the pigmented cells, Smoker's cells, Smoker's macrophages. And it is not typically bronchiole centered. It will be interstitial based mostly. It will not be typically bronchiole centered. Clear? So this is the major difference between a RBLD versus DAP. At the same time, you will see additionally desquamated cells, desquamated alveolar epithelial cells, alveolar epithelial cells. So this means that's the reason it's called as desquamative interstitial pneumonia. Then the third one, this is pulmonary Langerhans histiocytosis. So what you will be typically seeing in pulmonary Langerhans histiocytosis, previously it was called as eosinophilic granuloma. Eosinophilic granuloma. So why it was called as eosinophilic granuloma is the fact that there will be accumulation of eosinophils in the involved area. So that's why this name is initially a misnomer. It was kept because they saw a lot of eosinophils in that area. So they thought this disorder is to be due to eosinophils. But actually it is not due to eosinophils. It's actually due to the Langerhans cells that are getting accumulated. It's like a neoplastic lesion only, but we consider as an ILD as of now. You can see here, lot of eosinophils are getting accumulated in the interstitial zone. Clear? But the most important thing is the Langerhans cell that you see, and that's what you have to prove. So let us first see what you will see. There will be inflammation, which will be typically in the interstitium, which means this is an interstitial inflammation. This inflammation will be made of mononuclear cells. That is probably many times histiocytes also will be admixed, and you will see eosinophils predominantly. And this lot of eosinophils in that area has led to the name I told you before, that is eosinophilic granuloma. But the definitive diagnosis you can make once you do an electron microscopy. Once you do an electron microscopy, where you can see some tennis racket shaped granules referred to as something called Birbeck granules. At the same time, if you do a histology and staining also, these Langerhans cells that are present in this lesion will stain positive for CD1A. Very, very important. They will be positing CD1A positive. At the same time, they will be S100 positive. These are very, very, very important facts. CD1A positive and S100 positivity. Remember this Birbeck granules, CD1A positivity, S100 positivity, all these things we have already discussed enough in the hematology section under the histiocytic and dendritic cell disorders. So no need to again show you those images, but this is one of the images which I want to show for pulmonary Langerhans histiocytosis. So very importantly, what you have to know about the pulmonary LCH is the fact that they are cystic disease predominant in the upper lobe, young smoking males, and they have a high risk of developing pneumothorax, even though they usually come with cough and dyspnea, dry cough and dyspnea. And biopsy will show Langerhans cells with CD1A positivity. Since there are a lot of eosinophils before, they are called as eosinophilic granuloma, but this is a misnomer. This is not a problem here. The Langerhans cells are creating a reaction there. So which are typically CD1A positive, very important point, and S100 positive. Plus, in electron microscopy, these Langerhans cells will show tennis racket shaped Birbeck granules with or without terminal dilatation. Clear? So with this, we are completing this very, very short topic, that is smoking related ILDs. As I told you already, the smoking cessation is going to be a quintessential part of the treatment, and at the same time, they have a very, very good response to steroids. So overall, the smoking related ILDs generally tend to have a very good prognosis, because you have the etiology that if you remove, definitely this is going to resolve. And there will be no extensive fibrosis or honeycombing in these disorders, which means it tells you it's a poor prognosis. So since there are a lot of ground glassing without any architectural distortion, they're going to respond very well to steroids, which I have discussed already in the previous video. Fine. So let us stop with this and we'll move on to the occupational lung disease in the next section.